better than that? Well, this 5-year-old boy has been admitted with pyrexia. He's got a flu-like illness. He's complaining of earache. And he's also quite dry and a little hypotensive. But does he need more volume? Well, let's measure his stroke volume. This is using the sternal notch, looking down at the aortic valve, and we're measuring his stroke volume beat to beat in real time. His stroke volume is about 28 mils. Now we get Mum to raise the legs. His stroke volume increases to 34 mils, a very useful increase in stroke volume. He must therefore be on the underloaded side of the Starling curve. He will respond to preload. Now this simple test can be done as often as we like. But supposing this child was overloaded, when we raise the legs, we would increase the overload further and his stroke volume would decline. Well, that's no big deal. We just put the legs back down and we're back to where we started. No harm done. Now let's offload the patient. So this very simple test, along with continuous stroke volume measurement, gives us the answer to where we are on the Starling curve. Now, volume resuscitation is practiced every day in every hospital in the world in a wide range of conditions. What they all have in common is that what they are trying to do is either to increase the blood pressure or they're trying to increase blood flow, i.e. they're trying to increase cardiac output. Now, a clinical observation that I'm sure we've all made at time to time, the response of patients to volume loading is variable, from a very good response to little or even no response at all. Now, why is that so? Can hemodynamics explain that? Well, you bet it can. Firstly, as we've seen, it depends a little where we are on the Starling curve. If we increase preload by about 30 mils, then in this situation we get an increase in stroke volume of about 20 mils because we're still on the left side of the Starling curve. That same increase in preload here, however, results in a much smaller stroke volume because we're now approaching the apex. Now, if we carry this further and we go to the apex of the Starling curve, then an increase in preload will produce no increase in stroke volume. And as we've seen, if we carry on further, we may even see a decrease in stroke volume as we move to the right side of the curve. So that's one explanation for volume responsiveness. But there's another and perhaps much more important answer. Could it also be due to variations in the inotropy level, variations in myocardial contractility? Well, why is inotropy important? Well, these basic formulae that we learnt at the start, blood pressure is systemic vascular resistance times heart rate times stroke volume. Stroke volume times heart rate, of course, is cardiac output. So these two vital parameters, blood pressure and cardiac output, both depend crucially on stroke volume. And stroke volume, as we know, depends on preload, inotropy and afterload. So where does fluid loading come into this? Well, unfortunately, our fluid loading is trying to increase BP or trying to increase cardiac output. But there is no direct pathway that links fluid loading to BP or to cardiac output. Fluid loading only works by increasing ventricular preload. That then feeds into inotropy, and inotropy has to respond to that preload so that we can effect an increase in stroke volume. So fluid loading has to go through grand central here, which is inotropy. If we have insufficient inotropy, we cannot control stroke volume. If we can't control stroke volume, then we can't increase it. And then we can't increase cardiac output, and we can't increase blood pressure. So inotropy is central to hemodynamics. So let's go back to our Starling curves. Well, in this patient, yes, we'll have a cardiac output around a stroke volume of 50 mils. We increase the volume, and our stroke volume goes up by about 25 or 30%. Very useful. But what about this patient? If we increase the ventricular filling from here to here, i.e. we double the ventricular filling, then our stroke volume will change only minutely. What we need to do is take this patient and move them to a different curve. They need to switch tracks. We will never achieve a useful stroke volume in this patient, however optimal their preload. We need to change their inotropy. But if we do that, now let's look at what happens to stroke volume. So in terms of bang for our buck, we get far more in terms of stroke volume from increasing inotropy in this situation than we could ever achieve by using fluid. Now, last month in critical care, Stephen Thiel and his colleagues down at St. Louis, Missouri, published this paper on non-invasive stroke volume measurement and passive leg raising, rather as we saw in the video clip. And they showed that in medical ICU patients, they could prove 90% indication of fluid responsiveness by the response to stroke volume to leg raising. Now they were looking at a 15% increase in stroke volume 2 minutes after the onset of passive leg raising. In our series in Bathurst, we looked for a 10% increase in stroke volume at any time up to 2 minutes by using continuous stroke volume measurement, and we found that it was about 95% predictive, both positive and negative, of fluid responsiveness. So we're finding pretty much the same kind of results as St. Louis. Some more numbers that come into USCOM. Peak velocity. What does that have anything to do with hemodynamics? Well, just imagine a baseball pitcher. The speed that ball leaves his hand will depend on the power of his arm. The more powerful the pitcher, the faster the ball. The same is true, all other things being equal, of the myocardium. The more powerful it is, the faster the ejection velocity. Cardiac output, cardiac index, well, very simply, are we dealing with a trickle or are we dealing with a flood? How much blood are we pumping? Minute distance is an unusual concept unless you're used to echocardiography. But in effect, it boils down to the mean aortic flow velocity. How fast is the blood flowing through the aortic valve? Now this actually gives us an immediate indication of the state of dynamism of the circulation. The normal is 14 to 22 meters per minute. Above 22, the circulation is hyperdynamic. Below 14, the circulation is hypodynamic. 14 to 22, the circulation is normodynamic. Very quick, very easy, and it's the very first thing I ever look at when examining an USCOM data set. So think minute distance, dynamism. Stroke volume